Friends, except in acute coronary syndrome, in the management of chronic stable angina, we are directed or allowed to open only flow-limiting obstruction. Chronic total occlusion may not be a flow-limiting obstruction unless you find that A, it has produced angina, or objective ischemia in asymptomatic individuals, or demonstration of a viability in the segments subserved by the totally occluded artery, or you anticipate or expect that there may be improvement in LV function, or it improves the survival overall. Angina, typical of CTO, is a walk-through angina. What may happen is that once the patient is produced ischemia after some degree of physical exertion, there could be recruitment of collateral circulation and angina disappears. In multivessel disease, it may be very difficult to decide the culprit artery, and since opening a CTO requires a lot of efforts, a lot of time, a lot of use of hardware, dye and radiation, one must make sure that the totally occluded artery is responsible and the culprit artery producing angina. This is, I think, is very essential. Again, in multivessel disease, the non-invasive investigation may not be very reliable. Totally occluded artery producing large and extensive ischemia may sometimes be masking the ischemia in the other territory when the ischemia is studied by the perfusion study. So therefore, I think we need to have really a very specific answer and a definite answer by multiple investigation. Stress test, as you know, is not lesion specific, and lateral wall ischemia is very often not very easily accessible to the studies. Second question is a viability. This, I think, is extremely important issue. If you find that the myocardial segment is at rest kinetic and on exercise or stress it becomes hyperkinetic, that's normal. If it is kinetic and it on exercise becomes hypokinetic, the segment is ischemic. If it is akinetic and on stress also it is akinetic, then I think the issue arises. In the past, we were very much disappointed, and our approach to an akinetic segment as recorded on echocardiography was very disappointing, and we were very pessimistic about it. Well, the truth is that akinetic segment is not necessarily irreversibly dead. It could be stunned, it could be viable and hibernating. What is the difference between a stunned myocardium and a viable or hibernating myocardium? Both stunned myocardium and viable and hibernating myocardium, both of these myocardiums are non-ischemic. In a stunned myocardium, though the antegrade flow is normal, the area is adequately perfused with the blood, but the myocardium is stunned due to a recent injury and refuses to move. It's a sick myocardium, injured myocardium is stunned. Viable myocardium, also at rest, is akinetic. It's not dead, it is very smart myocardium. It is down-regulated its requirement so that that area also is not ischemic, because whatever less blood supply it receives is still sufficient enough for it to be alive, but it refuses to work. Let me give you a couple of examples. This patient came in cardiogenic shock. He had a pacing wire, as you see here. He had a pulmonary artery catheter monitoring the pulmonary artery pressure, and also intra-aortic balloon pump. As you saw in the earlier film, that this patient had hardly any circulation on the left side. Whatever I could do, I tried to do, so I tried to open up the circumflex artery here, and was wondering why this patient is in such bad cardiogenic shock. after opening the circumflex artery, we realized that this patient has a retrograde filling of the completely an anterior descending artery, which I think was responsible for producing anterior myocardial infarction and cardiogenic shock. Imagine if this patient, he had a chronically totally occluded artery, if this artery was open, this patient would not have such disastrous course when the circumflex artery was occluded completely. So therefore, this shows that in retrospect, sometimes a chronic totally occluded artery could be a very supportive artery in case an event occurs due to artery which is previously was normal. This is a patient who has a total occlusion of his LAD artery. This artery was crossed initially with pilot wire, and we took 1.5 10 millimeter long acrostate balloon, but it failed. We changed the wire to miracle wire. Changing the wire several times within the lesion or while crossing the lesion is very common, and multiple strategies are often involved while doing a CTO. And wire movement with this wire was able to cross the chronic total occlusion all the way down, and then subsequently the lesion was we changed the wire by taking another wire by the side and removed this strong wire, as has been discussed earlier while doing live demonstration, and then this lesion was adequately dilated. There were several more lesions which I do not wish to waste time because we have less time, and all the lesions were dilated with total arterial revascularization. Important thing is to demonstrate viability. This is the patient who had a CTO of an LAD, and this patient then subsequently received revascularization interventionally, and on 20th June, prior to the procedure, his left ventricular ejection fraction was 32%, and he had a large area of perfusion defect which was reversible. After the plasty, just 1 year's time, on 30th August 2001, his ejection fraction jumped to 52%. Why hibernating myocardium takes such a long time to recruit is not very clear. But certainly, you know that the left ventricular ejection fraction is an independent predictor of survival. When the improvement in the ejection fraction takes place, it changes the outcome and the prognosis of the patient completely. This study is a 12-month clinical outcome of a totally occluded artery with a successful revascularization of a CTO vis-a-vis comparing it with where the CTO revascularization had failed. Cardiac death, need for a CABG and any lesion revascularization in future at the end of 1 year, as you see, was statistically significantly lower in those patients in whom CTO revascularization was successful. How does viability make a difference, and why should we make more efforts and complete efforts to establish viability before attempting CTO revascularization is demonstrated adequately here. If you do the revascularization as vis-a-vis with medical treatment in those patients who have a presence of viability, the mortality is very, very low. Whereas those patients who do not have any viable tissue, a revascularization attempted interventionally is not different as compared to management medically. So therefore, I think viability establishment is very necessary. Hibernating myocardium or a viable myocardium is a very smart myocardium. You should suspect when on dobutamine stress echo, the mobility is seen in akinetic area. If on the PET scan, there is an FDG uptake by mitochondria, if post-extrasystolic bit shows potentiation or the pressure rise, collaterals are present and the wall thickness is preserved. However, I must say that there is no foolproof method to prove or disprove presence of viability. So if your clinical judgment or if your feeling or inkling that there could be a viability and if the CTO could be attempted easily, I think you should offer the revascularization. When the CTO is the only lesion, then I think your responsibility to emerge out successfully is more. Patients should have symptoms and viability, and the probability of success should be judged on angiographic findings to be high before you attempt. And this artery, may it be remembered that though it is a single artery and collateralized, it should still be treated because it could be a potential donor artery for any other artery getting blocked and producing an event. And when not to attempt, Pratap Kumar touched it briefly, if the distal segment is not seen, I think attempting a CTO is an inviting perforation. Moreover, when the distal segment is not seen, the revascularization may not be successful and may not be necessary because there may not be any viability. Relative contraindications are chronic renal failure, valve disease, large and risky area, and also when the patient's ejection fraction is very, very low. Mind you, these are not absolute contraindication, but they are relative contraindication. And finally, attempt to open a CTO when the patient has symptoms related to a CTO, when there is a large viable area and the territory is subserved by the CTO, an operator has a reasonable experience to offer the procedure quite safely and the risks are acceptable. Thank you very much.